Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I'm Rincy, the founder of Overcome, and today we are joined by a very special guest, Dr. Margaret Liang. So Dr. Liang is a gynecologic oncologist and health services researcher focusing on financial toxicity in cancer care at the Cedars Sinai Cancer Center. She joins us today to highlight and to talk about financial toxicity and its impact on ovarian cancer and our overcomers, and also helps us navigate ways to overcome. So join us for the next 45 minutes to an hour as we chat with Dr. Liang to talk about financial toxicity in ovarian cancer. And if you have any questions as we go along, please type in the comment sections below and we will get it addressed post the discussion. And as I always say, please share this information far and wide with anyone who may benefit from all these great insights Dr. Liang is going to share with us today. Have your coffee ready, because I have mine as we connect over coffee with there you go, Dr. Liang. So with that, a huge welcome to you, Dr. Liang, to this episode of Connect Over Coffee. Such an honor to have you with us.
Thank you so much, Rincy, for having me. I really appreciate it.
Thank you. So, you know, we hear this term pretty often, right? Financial toxicity. So before we get into details about, and we have an hour to talk about this, but can you please tell us about what this actually means in terms of cancer care? Just briefly.
Yes. And of course, my dog has just already started barking, but we're going to ignore her for now. Okay. So toxicity is a medical term that doctors often use to talk about the side effects of treatment, like chemotherapy frequently. So this term financial toxicity was coined about 10 years ago. I have to in a second, but
dogs are welcome, by the way. They have something to say. All good.
I know. So it's a way to think about, the financial burden that patients may be experiencing during treatment. So just like we think about any other side effect of treatment, so hair loss, nausea or vomiting, fatigue, we want healthcare providers and healthcare team members to think of the financial burden that patients may face just like that. So we're sort of addressing it in the same way in a proactive manner and managing it during treatment. And that can be from out-of-pocket costs, but also like the time costs that patients are spending through their diagnosis, treatment, and even surveillance.
Okay. So, you gave us a really good introduction. So in terms of, when we are talking about financial toxicity, and there are metrics to measure it, right? So how would you define the metrics that you use to measure financial toxicity, and talk to us about how does it impact the overall quality of life for our overcomers while they're going on, undergoing treatment, and not even just when they're in treatment, but before, after, the whole spectrum, right? And how is it related to overall survival of our patient community?
Yeah, so as far as measuring it, I think there's sort of two main categories of way we can measure it. So one would be the subjective experience that patients are facing. So the distress, burden, hardship that patients are feeling. And there are actually several tools that we use, which I'll talk about a little bit later, that we ask patients, how stressed are you feeling about your finances? Do you feel like that you have enough money to cover the cost of your care? Are you worried now about the possibility of you working while you're on treatment and making income to be able to support your ability to pay for bills? So a lot of that is important to us because really at the end of the day, it's what the patients are going through and their caregivers. There are also some objective ways we can measure it. So clearly we know patients, for instance, who go into medical debt or can no longer pay their utilities, or maybe they're spending a certain percentage of their income. Often in studies, we use 10 to 20% of the income is completely going to medical care. On the most severe cases, bankruptcy, those are clearly like measurable things that are concerning for really how devastating potentially the financial hardship of cancer care can be. And we really want to try to actually, again, my whole thing is to be proactive to prevent those downstream effects from happening for patients. In terms of your question about quality of life, there have been, in the last 10 years, that's where a lot of the research has been done on this topic. There have been several studies in all cancer types, and then I've done as well some of my colleagues' ones in gynecologic cancer specifically. And we definitely see that patients who are experiencing more financial distress, using different measures, the cost tools, one I can tell you more about later, definitely tracks with if you have more financial distress, patients also have worse quality of life. And similarly, if patients have less financial distress, patients in general are overall having better quality of life. And that can be in lots of different categories. So overall quality of life, fatigue, physical well-being, et cetera. I think the question you ask about how it can have an impact on overall survival is really important. So we know, there have been studies basically showing that patients, and I'm going to use oral medications as an example because those are things that we often pay more out of pocket for.
Yes. Mm-hmm.
So patients who are on oral cancer drugs that have high out of pocket costs, so the patient is paying more compared to another drug that might be a cancer drug that's cheaper. Maybe it's been on the market for longer. Those who have the higher costs are actually less likely to be able to either initiate their prescription or continue it as prescribed. And so we do think it seems to be directly related to the cost of care. And then beyond that, there have been some studies, it's not specific to ovarian cancer, but it was in all cancer types in Washington state. They were able to link actually cancer registry data with bankruptcy claims and found that cancer patients were more likely to go bankrupt than people who did not go through bankruptcy. And then of the people who went to bankruptcy, which clearly, fortunately, is not super common, although medical debt is the most common reason people go through bankruptcy. Of the cancer patients who went bankrupt, they actually had worse survival than cancer patients who did not go bankrupt. Mm-hmm. So that's sort of some of the data that we've shown that there actually may be an impact on patients' cancer survival. There's another study that looked at cancer survivors, those people who were like several years out from their diagnosis, and did seem to find a very small, worse survival for, again, patients who had reported that they had more difficulty paying for either their just medical services or dental services.
Mm-hmm. Thank you. And so you were talking about the tools, right, that are now being used in clinical practice to even screen for patients who may be experiencing this financial toxicity, right? So that piqued my interest. So can you tell us about these tools that are being used? How do you implement them in trying to screen the patients who are experiencing financial toxicity or, prone to or about to? How do you screen these patients?
Yeah, so probably the most common one that's used in practices, so like in clinics or offices, is currently it's the National Comprehensive Cancer Network, so NCCN distress thermometer. So there's a picture of a thermometer typically, and it sort of has a scale of 0 to 10 and asks patients to indicate what level of distress overall they're having. And then the follow-up question really has these different categories of different sources of distress. Since we're talking about financial toxicity, the category that most goes along with that is sort of like the practical concerns. So are you worried about childcare? Are you worried about transportation to and from your appointments? Are you worried about paying your medical bills? All those types of like working, et cetera. So it has a way to indicate that. And then the goal is to screen patients, before they're starting treatment and maybe at various time points, like every 3 to 6 months. If someone's starting a new treatment, those might be good times to screen. And if the team is screening, then hopefully we can link patients to resources where they might have either counseling or financial assistance resources that are locally available that can hopefully kind of, again, proactively address these issues before it becomes really severe and might have an impact on, patients' ability to get to all their appointments and treatments as planned. That's probably the most common one. Some of what myself and colleagues that are studying this are kind of trying to, that's a really general distress screen, which is really important because we also do care about, are you worried about talking about your diagnosis to your family? Are you having numbness and tingling and so you can't do the things you want to do? So we do care about all those categories. But I think from a financial hardship standpoint, we're kind of looking, maybe there needs to be another, again, short tool, because we know answering lots of questions can be hard, that's really focused specifically on financial hardship. So to that end, probably the two most other common ones are one's called the COST score, so COST, the Comprehensive Score for Financial Toxicity. That's really asking patients their like sort of subjective experience of what's going on. Are you feeling more financially distressed because of your cancer care? Are you worried that you can't work the number of hours that you can? Mm-hmm. Those types of things. And then the last one is sort of more like what's often called like social determinants of health. So things that are not maybe directly related to your care, but can you afford like the basics like food, shelter? Can you pay your utility bills? Can you pay your credit bills? Are you having to go into debt? So a lot of these screening instruments, we don't know exactly what the best one is, and lots of them are being tested or used in different clinics. But I think at the end of the day, if we screen everybody sort of universally, then it can become a normal component of care, hopefully, so patients don't feel like ashamed or embarrassed bringing it up to the care team. Because at the end of the day, what I want to encourage patients is like, your care team wants to know these things because we know that going through cancer treatment is a lot. And so there's usually someone there to help, right? Like a social worker, or your doctor can choose a different drug that might, be cheaper. Sometimes there's financial counselors or patient navigators. So I think this is a way to ask everyone, so it kind of normalizes the fact that we need to talk about it.
And that's a really good answer. Thank you very much for that. So I have two just follow-up questions that is in my mind as you were talking. So I think you answered the first one in saying that majority of the institutions, majority of the treatment centers use this screening technique. Is that correct? I mean, given the fact that, the reason I'm asking is from what we do at Overcome, we can see a huge disparity between big academic centers versus, community hospitals, and what there's a disparity in every situation, every angle. So what I'm asking is, this kind of screening sounds very good and it seems robust. So is it being used? You use the term universally, so I'm just going to ask you, from your experience, do you feel that majority of the hospitals or institutions across the country are using this particular screening tool? And then what percentage of patients, off the top of your head, I'm assuming this is not required, this is an optional screening. So what percentage of patients actually provide that information to the healthcare teams?
Yeah, great question. So I would say you're right. So the concern is it really being used widely? So I would say for the most part, there's usually some sort of screening, but it may not be what I described. So the distress thermometer, when they've done surveys of cancer centers, some community and some academic, many places use the distress thermometer because it is used a little bit in some of the credentialing processes for cancer centers. And then I think there is a movement to do some of the social determinants of health, again, like sort of the basic needs, transportation, housing, utilities, et cetera. One nice thing that's coming that I would think will help encourage broadly more practices to even get on board with this is the Association of Community Cancer Centers, which really leads the charge in, making sure that, okay, sure, maybe the large cancer centers have more resources, but how can we make sure that the same care is being delivered to maybe a smaller hospital that might, again, have like less resources to be able to invest in that? They actually are working on, I think they're going to present in the next few months, because I've been talking with them. They're actually providing like a toolkit for practices to say, okay, this is how you can basically create what's called a financial navigation program. So in the big picture, it'd be basically, let's screen everyone, again, to normalize it and understand that even if you have insurance, you may be dealing with these issues. Even if you're whatever income, low income, high income, medium income, all these, this is a problem for everybody. So implement screening and then develop reasonable workflows, knowing that different hospitals and cancer centers may have different numbers of personnel and resources and things. But how can you provide at least like the minimum, link patients to available resources, whether they're in the community or the health system, or even online, like national organizations. So it's going to be nice because they're going to kind of make like a toolkit for practices to use, and then also show like, okay, if you're having a problem with this part of implementing the workflow, basically, this is like something you can do, and provide trainings and things like that. So I think that's going to help even more broadly expand it. So I would say the majority of places are doing it, but probably not all. And again, that hopefully will help. To your second question, so in general, when we've done research surveys, so, it is a specific population of people who have agreed to be in a survey research study, but across all cancers, as well as gynecologic cancers, which includes ovarian cancer, the rate of having financial distress or financial toxicity is usually ranges between, so 50% is probably on average, and it can range between like 30 to 60%, depending what group of patients you're sampling. So it's kind of a testament to like, okay, so the average is 1 in 2 basically of patients are experiencing some sort of distress about paying for their cost of care, or some of the impact about, again, all the time that they're not doing other things that they would otherwise be doing, that they're dedicating to their care.
Okay. So, so I was reading that financial toxicity is experienced by the patient in three primary domains. So can you talk to us about what these domains are and what should our overcomers know and be aware of?
Yeah, so I think this is a good way to kind of organize when we're thinking about how to solve this problem or improve the problem. I think it's not going to just be one solution. It's going to take lots of different, smaller solutions. But it's a good way to sort of organize what, again, the downstream impacts on our patients and overcomers and their caregivers. So the three domains or categories are, so one is material conditions. So this is thinking, okay, now I'm spending a lot of money now on my medical care that I wasn't previously doing it. So, can I not pay for other things? Like at the lowest level, leisure activities, but clearly that's important for patients' well-being. But maybe again, on the more severe level, like your utility bills, you can't like keep electricity on. And then next would be like, oh, am I using up things like my savings or things that I was going to use for my child's education or retirement? So, or getting credit card debt or actually going into debt, and like we talked about bankruptcy. So those are sort of like all the material things that are important and kind of support our like livelihood in general. So that's sort of the first category. The second category is psychological response. So we kind of touched on this, but understanding that having a cancer diagnosis, going through treatment and dealing with all of those things can be very overwhelming and stressful. And so this is like an additional stressor that we have now is, okay, I'm also trying to do all the things I can to make sure I have the best possible outcome possible with my treatment and my diet and exercise, et cetera. And so recognizing that this is an additional stressor. So what impact is it having on sleep, anxiety, depression? We've done some interviews actually with ovarian cancer patients, and they've talked about, always being able to be the sort of the primary caregiver for like their entire family. And suddenly they, feel ashamed almost that they are now so reliant on people, and maybe they need to ask, neighbors or people for either money or help and things like that. So, so recognizing that's an important component. And then the last one is called like health-related coping behavior. So this is saying, and we've again also touched on this, but like, okay, so I'm trying to go through my treatment, but because the costs are kind of, maybe more than I can handle with all the other things I'm managing as a patient, then maybe I'm like gonna like skip my pills and take them every other day to make them last longer, cut them in half, or I'm gonna wait and get the CAT scan until I get 2 more paychecks and I can afford the copayment or the upfront payment. So clearly, we also care about that portion because we really want to be a team with patients and their families to really make sure that they're able to do the treatment as best as they can. So.
Thank you. And so I was actually reading, in one of the articles that gynecology cancer patients with high financial toxicity are 4 to 7 times more likely to report, as you just mentioned, delaying or avoiding medical care, and 4 to 6 times as likely to report medication non-adherence compared to those with low or moderate financial toxicity, right? So this is huge, given that every day is important towards enhancing our quality of life, but based on this challenge on financial toxicity, patients are having to delay their treatment or just not taking their medication as you're talking about. So this directly impacts their physical health. I mean, this is a challenge that tell us how we can overcome this. How do we navigate through this? And what have you seen through your research, and what kind of guidance could you share with us on that?
Yeah, absolutely. So I kind of think about it like, again, I don't think there's going to just be one solution that's, going to solve this. So I kind of think about each of the people that are like involved in this. So like thinking about, okay, what can patients and their caregivers do? I do think, again, thinking of it as a team, because traditionally, I don't think we talked about this a lot, 10 plus years ago before financial toxicity even became a term. So, yeah, there can be screening at practices, which is a good way to start the conversation and help us identify needs. But I do think as a patient, I encourage patients to, speak up, and your care team actually wants to know these things and wants to be there to help support you and make sure that you can adhere to the recommended treatment and have the best outcome possible. And then I do think similarly, and I'm doing some research, like how can we help, we as like a healthcare team and even society, help patients and their caregivers like navigate the complexities of like even your insurance. Like there's so many things that can be super overwhelming. No one teaches us this. So kind of learning like what is the terminology, and if something isn't covered, what can I do if my insurance denies the treatment? What can someone as a patient, but also like the care team. So again, I think a lot of it is just like proactive communication. On the other hand, similarly, doctors weren't always trained about these topics, again, because we knew it was an issue, but it was almost like, oh, okay, the doctor just needs to like prescribe the treatment. We don't want them to think about the cost, because at the end of the day, we want them to just to prescribe the, best treatment available. But I actually think it's important, and there is a push to like actually educate the care team, so the providers, doctors, nurse practitioners, nurses, on the impact that patients are experiencing, so they can understand, okay, sure, I may not, be able to like click a button and see what a patient's treatment is going to, cost, because unfortunately it's not very transparent in our health system. But if I kind of have some awareness about things that I can control, so like, okay, maybe there's some treatments that can be given every few weeks rather than weekly, and they have the same effectiveness. Maybe there's, a generic version of the nausea medicine, that's cheaper. Maybe I can, use, after COVID, now there's a little bit more telehealth. So maybe certain visits may be appropriate. Like genetic counseling, I would say, is a common one that's becoming more widely available through telehealth, where you can do your genetic counseling visit like via video or phone. So what are ways that, again, not just thinking about the out-of-pocket costs, which maybe us as providers, we can't control a lot because it does have to do with insurance and things like that. But what are the things, maybe we can put CAT scans and doctor visit on the same day. So instead of 2 different trips, where someone's driving an hour each way, it's just 1 trip. So I think we can be much more mindful and strategic. But so I think from both standpoints, communication is key, and we really want providers to be more proactive. So those are just some examples.
Yeah, absolutely. Thank you. And like you said, it's a two-way communication, because unless you cannot act either way, right? So,
yes.
And like you said, just your example on having the doctor's appointment and the CAT scan on the same day, it doesn't, from an overall scheme, standpoint, it doesn't seem too much, but also, when you add up those little things, I mean,
yes.
little costs, it can get, prohibitive. So as much as we can control and minimize and make it efficient, I mean, it's better for the patient and their families financially. So thank you for sharing that. So when we review the risk factors for financial toxicity, do you typically see an uniform interplay, or are there disparities that are based on race, age, religion, location, all of those things? And because disparities these days is a huge topic, and we should talk about it and we should address it. And so in my mind, when I think about financial toxicity, we know that there are ethnicities, ethnic groups versus not, that could be more predisposed versus the others. And so can you shed a little bit more light into that?
Yeah, so in studies where they've looked at all cancer types, and then also the studies that have looked at gynecologic cancers, including ovarian cancer patients, it's actually pretty consistent. So a lot of the main risk factors are younger age. The reason we think this is because younger people are still working, so they're more likely to really notice the impact of suddenly not working potentially, or working less, during treatment.
Just to interject, when you say
yes.
young, what is your, what
Oh yeah, thank you. Yeah. So usually the studies have used like less than 65, just because it's the cutoff, because this is the second point I was going to use, for Medicare eligibility in the United States. So everyone is eligible for Medicare, after, or almost everyone after 65. So it's sort of like an equalizer, because now patients have access to similar insurance, versus younger patients often are relying on employer-sponsored insurance, or maybe insurance from the marketplace, or depending, low-income patients may use Medicaid. They have done studies where they've broken it down by like decade of life. So like 30-year-olds, 40-year-olds, 50-year-olds, and have similarly found that younger patients, like 30-year-olds compared to 50-year-olds, seem to have more financial toxicity. So, because I think part of it is the working part. So, they may be more likely to have an impact on their job if they're working. And then also, if you're younger, often patients haven't, accumulated as much savings earlier in their life. And then again, the Medicare thing, I think, kind of helps normalize things once patients are over 65 if they're eligible. So, yeah, female sex is another one, which clearly impacts, ovarian cancer patients.
Why is that?
Farther,
Do you know why?
yeah, I actually don't know that we have an explanation because even in cancer types that actually impact both sexes, um, I don't know that we have a clear explanation, to be honest. Yeah, I could only hypothesize, things with caregiver roles, things like that, and perhaps potentially that could be a reason, but I don't think we have explored that and know really. Um, and then farther distance from a treatment center sort of seems maybe not surprising to patients and their families because a lot of the interviews that I've done with ovarian cancer patients on this topic really talk about transportation as a huge thing. So like frequently patients, depending on the treatment, like need a ride basically because they can't, because of whatever treatment they're on, maybe they can't drive themselves as an example. So it's not just the patient not doing whatever they would be doing, otherwise with their time working, taking care of someone else, et cetera. But now it's like a second person who's having to take, time off work to drive. So I think that's probably explains some of the farther distance. Uninsurance, so like not having insurance definitely is a risk factor, although I always emphasize like in this day and age, really there's a lot of underinsurance. So just because you have insurance does not mean you're protected from this. And I really like emphasize that, especially to the providers and care teams. So they kind of recognize, certainly we want to support people who don't have insurance because, they don't have anything sort of protecting some of their out-of-pocket costs. But really, there's a lot of underinsurance at this point where patients are still facing very high out-of-pocket costs despite having insurance. Those are the common ones. There is some kind of mixed data about like if patients who have chemotherapy are more likely than people who have, just surgery, which kind of intuitively makes sense because the treatment may be for a longer time. But again, that's sort of mixed. And then lower income, which also makes sense because that's sort of like what the patient's financial status is before they even are having to try to deal with these new costs.
And in terms of ethnicities, have you seen anything when it comes to financial toxicity, like, different ethnic groups reacting differently?
Yeah. So non-white race. So in the studies, primarily it's Black patients are being compared. So do have more financial toxicity. And that is typically even when they're controlling. So they're like controlling for like income levels and things like that. So there definitely is a disparity there. Again, I don't know that we have like dug deep enough, to know exactly what's driving it. But certainly you could see this issue kind of like you were talking about. Maybe patients delay even like going to be seen for whatever symptoms they're having. Again, some of the disparities with, Black race or lower income, et cetera. So because of cost, this is actually maybe causing some of the disparities we see later in both diagnosis and treatment. So I do think it probably contributes in some way, but again, I don't know that we like have totally mapped it out and completely understand it yet.
Right. And thank you for mentioning that because I do feel that, if we were to do more in-depth research on all ethnic groups, I know that you mentioned that right now it's kind of focused on the African Americans versus the others, but I feel like, the other ethnic groups would probably portray kind of a similar trajectory. Possibly.
Yeah.
So
yeah, no, I agree.
Yeah. And so in general, with patients with ovarian cancer, are they at a higher risk for financial toxicity for whatever reason, or is there any data to support, or can you tell us about that?
Yeah, so in the few gynecologic cancer studies that have included ovarian cancer, they haven't found a difference in cancer types. So usually ovarian, uterine, and cervical are the main ones. Right. I think it's because, these are still actually like more uncommon cancers if you compare them to like lung cancer or breast cancer or prostate cancer. So I think the problem is like the overall numbers are not big enough so that when you divide them into groups, you actually probably just aren't going to see a difference regardless. So the things that I think about for ovarian cancer patients that I actually do, personally think would contribute potentially to more financial toxicity is one that patients are often getting different modes of treatment. So surgery and chemo and maybe like a maintenance pill versus other cancers that I treat or others might treat where like the treatment might just be like one thing. So just surgery or just chemo. So the fact that there's many different modalities of treatment, I think is going to contribute. And then similarly with the increase in the use of maintenance therapies where patients used to maybe be on treatment for a more confined period of time, but now with like PARP inhibitors as an example, so patients who are prescribed that because they may benefit might be on that treatment actually for years. So patients are just on treatment, which has, both monetary and time costs for longer. So I think those are some factors that like really would be particular to ovarian cancer patients and then might make them more prone to experience these, especially over a longer period of time.
Yeah. Thank you. So you briefly touched upon, career and cancer, right? For the younger patients or even like, older patients who are still employed. So we know that many of our overcomers have to take a break while they're on treatment, or sometimes even they cannot even return to work for many years because of the side effects, the after effects of the cancer therapy. So what implications do situations like these have on financial toxicity? And, from your research and the work that you have done, even in collaboration with the companies that they work with, et cetera, how can we possibly overcome these challenges when they need to be out of the workforce for limited or extended period of time because of the nature of the disease?
Yeah. So okay, let me try to organize this. So I think one thing is us as like a society, as a healthcare system, patients and caregivers, kind of building awareness of like what are some existing, I guess, protections might be a term we'd use, that patients can utilize during treatment. So understanding like Family Medical Leave Act. So that provides up to 12 weeks of, it's unpaid, but it protects your job and then therefore often employer-based insurance for up to 12 weeks in a 12-month period. Not everyone is eligible, but kind of understanding how to utilize that both for patients and then often, again, caregivers might have to use it to help patients go to and from appointments or support them when they're having symptoms. So that's one thing. Another thing is there is actually the American with Disabilities Act, which protects, like basically says that jobs need to provide work accommodations for patients with disabilities, and cancer actually qualifies as a disability. So understanding what accommodations a provider or employer may have to provide. Sort of interesting because if you like look at the specifics, like only certain employers actually have to like do this because it's based on like the size and type of company. But I'll put them here actually. So there's like several resources actually to help patients navigate some of this. So 3 websites. So Cancer and Careers is very focused on work and how to navigate that with cancer diagnosis. How much should I disclose to my employer? How much should I not? What are reasonable things I can ask for? Triage Cancer is another nonprofit that has tons of stuff specific to dealing with insurance, but also employment. And then Job Accommodation Network is the last one. And that one's really good because you can like click things that are like specific to you and they'll like try to help you generate a list of like questions to talk to your employer about. So I think that's one main thing, talking to your employer and how to navigate that and what are your rights and things like that. And then the other one, again, is kind of a theme here, like communicating with your care team. I think, I encourage providers to like ask everybody, are you working and how physical is it? And okay, are you going to be able to work part-time? And we'll kind of try to talk through, okay, maybe like the second and third weeks of your chemo, you actually probably can work. Maybe the first week you take off, it's different for everyone. But because clearly, like if we can manage patients' treatment schedule and make it more efficient, and then also manage their symptoms better, then patients are actually more likely to be able to work at least somewhat, or even full-time in some cases, but while they're during treatment. So like we play a role as providers also in this conversation and sort of helping patients navigate it. So I think patients and their caregivers kind of talking to both of those groups.
And I was just thinking that with COVID, one of the things that has happened is the remote work has really taken off, right? So for patients who are undergoing treatment and, given their relationship with the companies that they work with, it is possible to accommodate that way that, for the next few weeks or whatever, I mean, you can just continue to work from home, because that would make a wealth of difference to our overcomers if they don't have to do the everyday commute. And physically, it's also tiring to be sitting at the office desk versus if you're working at, in your own kitchen, or even sometimes from your own bed, right? It makes a difference. So these are some, I think minor accommodations that the companies could potentially make for our overcomers. And the other thing is I have personally talked to our overcomers, a few of them who tell me that, the ability to work while going through the cancer treatment is actually not only empowering, but it also provides them with distraction. It provides them, because those 8-9 hours a day, you are kind of focused on something else and not on the continuous, the treatments. And it's just very intense, right? When you're going through chemotherapy, surgery, all of those things. But those 8 hours when you're working, you're kind of forced to distract yourself from the treatment. So even from an emotional health standpoint, it can, not all patients, but in some patients, it may actually help for the mental health part of it, and also if they can continue to work from home, then that also helps their physical well-being. So I just feel like we need to have these kinds of conversations, and the healthcare teams like yours that you were talking about, that if you champion this for our overcomers and that the companies understand what they need to do, I mean, there could be a win-win situation here for overcomers. So thank you for sharing your insights on that. So, we talked about the stress impact of ovarian cancer, or any cancer, right? And so I've read a lot of articles, and you may know Dr. Anil Sood has done a lot of research on the impact of stress on ovarian cancer. And so to me, when I was thinking about financial toxicity, I couldn't think of a more major stressor than that, because we have an Overcare program, which is a national program, which we address this financial toxicity in ovarian cancer patients by giving them a package. It's an Overcare program where we give them gas cards, grocery cards, financial help for them to be able to pay their electricity bills, all the things that you're talking about. So we are very close to this, and we talk to our patients nationally about this, and so very well conversant, and we can see how it stresses them out on a daily basis. Now, financial toxicity can bring a lot of stress, and we know that physiologically speaking, stress can feed cancer. It can make cancer progress. So there's actually a physical manifestation of this, the financial toxicity. So has this been studied or researched, or undergoing any kind of study where you are actually linking all these and kind of understanding how does financial toxicity impact response to treatment and just overall well-being of our overcomers? And just talk to us a little bit about that.
So one thing I was thinking of, I'm actually part of this research network that just started 2 years ago. So I'm going to put in a plug-in, but it directly relates to your question. So it's called the Emotional Wellbeing and Economic Burden Research Network. So EMOT, EMOT econ, ECON.org is the website. But so, because I think what we've realized in the financial toxicity space is, okay, now there's been about 10 years of research. It shows, we know it's a problem. 1 in 2 patients face it. We know some of the risk factors. We know some of the downstream effects on, adherence to care and distress that patients are feeling, and that patients, maybe even go bankrupt and then have worse survival. But the space, and I'm going to focus on emotional well-being first, and then I'll answer the physical part. But like the emotional well-being component, besides like measuring quality of life, so we know quality of life is worse if you're more financial distress, but that's sort of like a very superficial understanding. So like, how is it impacting, and like what emotional coping tools that patients might use for, dealing with the cancer diagnosis, could we maybe like harness to help them deal with this additional stress they have? So examples being like gratitude practices, or resiliency, or, fighting back, and like, sort of like different personalities of like, some people, sort of try to avoid problems, but can we help them, use their support network and sort of empower them in that way? So that network is actually trying to bring together like psychologists basically that study that and be like, they are like, oh, okay, financial hardship, this is important, but we've actually never studied it. So kind of bridging the gap, because I think we can actually learn a lot from these two disciplines that will then, since I come from the financial hardship, standpoint, really help us better understand what tools from that space, like coping tools, essentially emotional coping tools, can we use to help patients deal with this? But then also, like, what is the emotional impact that we're truly having, on things that I don't have a lot of understanding, I'm just learning, that are also important, again, to how patients are going to do, because we do know that some of these characteristics, may impact how well a patient does during treatment at the end of the day. Right. So I think it's super early. And then I think to your impact, we probably know even less about the physical effects, but like you said, there is a lot of data that stress and emotional regulation and things like that can have physical manifestations, which clearly then kind of is like a cycle, right? If you have more physical symptoms or manifestations, it's going to more negatively impact your emotional well-being. So it's like this cycle. So I do think, again, that's even probably early. We'd probably know even less, but it's really important.
Yeah, and the thing is, we start somewhere. I mean, as now that we have recognized, to your point, there's 10 years worth of research has shown us that this thing clearly exists and it is impacting the lives of our overcomers. Then once we have that knowledge, we can continue to act upon it and kind of build those links that you're talking about, that, how does financial toxicity then relate to emotional well-being, then relate to actual physical manifestations, and how can we stop this vicious cycle, right? And that is the most important thing, because we are all working towards enhancing lives of our overcomers in whichever way we possibly can. So as long as we recognize it, we can take the next step. So thank you for sharing your thoughts on that. So and just switching gears, I thought I would ask you that if you were in the shoes of an overcomer for one day, and you knowing what you do about financial toxicity, what would you do to seek support from your healthcare team? What questions would you ask of your employer, your friends, or family? How would you navigate if you were an overcomer?
Yeah. So these are sort of like practical tips. So I think one is, if you have insurance, like, get to know it, because unfortunately you may be using it more potentially than a patient had been in the past. So one, like learning terms like premium, deductible, out-of-pocket maximum, copayment or co-insurance. And then a lot of the times, unfortunately, it does take calling your insurance company, but either going online if they have a benefits book, or just calling someone. One tip that actually a patient gave me when I was doing like a focus group is, like, you can actually, when you call insurance, ask for a case manager, so that you're actually talking to some insurances. You're like talking to the same person every time. So you don't have to like re-explain the whole story each time you come. So that'd be a good example, especially if you're filing like an appeal. And again, your doctor actually can help with some of these things depending what the issue is. But just empowering patients and their families to like get on the internet, the website, or call and get more information. Because basically, at the end of the day, I think some knowledge is power. The next thing I do think is talking to your care team. So talking to your doctor, your social worker, your nurse, not only about, okay, if you're having concerns, because really we want to actually talk about it before there's actually concerns. And then, so talking to them about any financial concerns it might even be transportation or working or topics like that. So being proactive, if they're not already screening, or being proactively asking patients and their families. And then I do think kind of thinking about the employer situation, using those resources, because I know it can be very overwhelming potentially for patients. Like, again, how much should I tell my employer? Like, yes, are they going to, judge me because I'm asking for these accommodations? So I think those websites, when I've looked through them, like, they actually, some of them have worksheets or like checklists that you can like kind of go through and be like, these things relate to me in my job and these things do not. Again, involving your care team, like your doctor, in the conversation, I think is helpful, because they may be able to tell you more about like what to expect as far as symptoms, both physical and emotional. And then other things that are sort of outside of the care team are like looking up community organizations. So Overcome Clue is an amazing resource, and Overcare is a great financial assistance resource. Again, when I was doing focus groups, patients were like, clearly American Cancer Society, there's the American Society of Clinical Oncology, Patient Advocate Foundation. These are sort of common ones. But one patient was like, I literally just Googled my cancer type and financial assistance. And there are some programs that you might otherwise not know about that are specific to ovarian cancer, for instance, and that the care team may not always be able to stay up to date with, even if they're, trying to. So that's sort of another thing. And then I do think other patients have also similarly told me, like, and this is Ovarcom is a great example, but like really leaning in on people that have gone through this before, right? They're often able to give way more tips because they're like, oh, I had that same problem. Why don't you look into this? You know, I remember a patient was like, oh, I like signed up for disability and it was really hard to find help from someone to sign up for disability. And I met someone at the support group who basically had done it 6 months ago. And literally this individual like helped me sign up for disability. And then they were able to get some, you know, sort of income because they were eligible like during their treatment, which helped a lot. So those are just some examples. So, you know, again, just encouraging open communication. I know can kind of be like a sensitive topic at the end of the day. No one really likes talking about income or costs and things like that. But, you know, unfortunately, it's a problem with our, you know, healthcare system and everything. So unless we talk about it, unless people know that it's an issue, it's hard to get help. So I do encourage patients, again, to feel comfortable. Yeah.
Thank you so much. So, you know, one of the things that we talk about, and you briefly touched upon this in the beginning about the cost of drugs, right, in the ovarian cancer treatment, and especially some of the newer drugs that are doing wonders for our ovarian cancer patients can be prohibitively expensive, right? So, you know, yet we have physicians recommending them routinely to the patients because from their perspective, this is something that is going to work for you and you should be taking it. So there's a gap here of what, you know, the cost benefit, you know, equation. So what are some of the best ways to navigate this challenge in terms of receiving the best quality care, but while striking a balance with like literally paying the bills and running the family? What would you recommend in situations like this?
Yeah. So I think one thing is, and health systems are fairly good at this, but I think patients still being aware just in case like this art is existing, they can kind of look into it. So like the most common example in ovarian cancer really is like PARP inhibitors or any like oral cancer therapy. So it's not covered by like your medical insurance, you know, your typical medical insurance, which makes it so that when you get an infusion drug, like a chemotherapy, usually you have actually pretty little out-of-pocket costs because it's under your medical insurance. But when something's oral, you use your pharmaceutical drug benefits, and then there are often like skyrocket, you know, like a PARP inhibitor, for instance, costs like $13,000 to $15,000 just if you were just like to pay completely for it. Insurance usually pays for the majority, but when we looked at Medicare patients and then privately insured patients in some databases, I mean, it was such a range. Like 50% of patients paid like $50 or less, which again, still could be a strain depending what patient's income level is if they're going to be on it monthly for years. But then there were some patients that were paying like $2,000 a month, which is like so much, you know, even more stressful. So there is a lot of movement actually within like the pharmacy community where like pharmacists, so their role used to be like, okay, let me cross-check drugs and make sure there's no interactions and let me maybe tell the patients more about the side effects. The doctor probably did too. But now part of their role actually is becoming, for these expensive cancer drugs, to also be like a navigator and like kind of proactively say, okay, if patients have a high out-of-pocket cost, maybe they use a threshold, or if it's just based on what the patient is saying, then they can also help sign patients up for, there's like copayment cards, which some people are eligible for, where they can reduce the copay monthly for it. And then sometimes manufacturers will actually provide free drugs, but certainly you have to meet certain criteria. So now, interestingly, the pharmacists are actually, that's like a new role that they're having. So a lot of the times there should be someone, whether it's a pharmacist or a social worker, that can help navigate that, because it can be hard, obviously, for the patient to navigate this on their own. Although a lot of the drug companies, if you like Google the website, will have like a financial assistance like packet that you could look at. So that's one thing. And I think, again, the key is really just communicating with your care team. Like, we would rather know that it's a strain and that you might not be able to take the drug, so we can see if there's an alternative or if we need to, you know, shift. And there's some weirdness about how drugs are packaged that sometimes impacts like how many pills patients need and sometimes can impact the cost. So it's a little too complex, again, just for the patient to know on their own. So I think really just encouraging patients to, again, communicate because the team wants to help. So try not to feel embarrassed, although I know it can be a sensitive topic at the end of the day.
Yeah, and you raised a really good point here about the dosages that you were talking about, the number of pills in a package, etc. Because oftentimes, you know, in one of my other interviews, I've had doctors tell me that, in certain situations or cases, let's take an example of PARP inhibitors. These are oral pills. So you could potentially reduce the dosage of your drug, but yet have the same kind of effect or impact on your treatment. So if cost is an issue, then maybe perhaps that's one route that, you could potentially kind of, if you communicate with your healthcare team, they may potentially look into it. That could we, reduce the dosage for this patient for the next few months to see, not without compromising the quality of care, of course,
Right.
but also kind of seeing that if there's a room to just exercise that option. So unless you communicate that, it is not possible for the healthcare team to do. So to your point, communication is key here. But there could be some ways to kind of try to navigate. Yeah. So, the other thing that we hear from patients all the time from our overcomers is just simple things that happens in hospitals, right? Right. Parking, for example, that each and every patient, I mean, I shouldn't say that it happens in every hospitals where there are, there's outside parking that's free typically, but I mean, it is in majority of the hospitals, let's say parking is paid. Yeah. And the patients have to pay for it. And then if you're going repeatedly to your center for chemos or other things, it just little things, right, that adds up.
Yeah, absolutely.
That's why we have the gas cards and other the options that we offer to our patients. But in situations like these, I mean, why? I know you cannot answer this question for the whole
yeah.
But just from your own, perspective, why are patients still being asked to park? I mean, pay for parking, and what could we do to kind of create some changes, make some changes to make an impact for the day-to-day, like little annoying costs that patients and families have to go through. I mean, while treatment, I find this completely unnecessary. And so
yeah, I agree. I mean, it's so crazy because I do hear that from my own patients. And there actually was a researcher at Dr. Chino in her group that like published on parking rates and like a little commentary basically of like looking at cancer centers on an average how much it was. So yeah, I mean, I do think one, building awareness both from like programs like this, from the patient and patient advocate standpoint, and then also from the provider. I think we just have to be louder essentially. And at some point the culture needs to shift. Like clearly at the end of the day, it's hard because, medical centers need to also make money to like sustain themselves. So it's there's a little bit of tension there. So, but I completely agree. Some of those things, it's like the tiniest thing, but could make actually a drastic impact on the patient's overall experience when they're already going through something really stressful. And I think kind of to that point, I think transportation is, I don't have a solution yet, but I do think transportation is like such a huge burden that is hard for medical centers to, can we use tech companies, ride shares and stuff? I don't really know, but I think that's a thing that is a kind of seemingly a small thing, but is actually a very big time and resource and like worry cost to patients, again, since they're often relying on caregivers or neighbors or, having to have a schedule with different people to come with them. It's just a lot. So I don't have the solution, but I totally agree with you. And would love to put our heads together, collectively as different stakeholders to come up with solutions.
Yeah, I mean, these are some of the things that I really strongly feel that we should spare our patients, and they're going through so much. I mean, if there's a way to, spike up the parking for non-patient groups, I will pay, if I visit one of our partner hospitals today, and if they tell me that a portion of we have increased your prices because we want to make the parking free for our patients who are coming in for treatment, I think majority of us would be okay with that. So certain like that, I feel that, the patients should not go through. And like you said, we need to keep talking about it, raise our voices. And so maybe that will help. And on the transportation thing too, we have talked to patients who tell us that, we had a choice of either, using our funds to stock our fridge versus, fill up my car with gas to go for treatment. So I chose to stock up my fridge because I have children in the house. So small things, and this is where we offer the gas cards to our patients, because we realize that this is something, small things, but it can have a big impact to their decision to carry on treatment and to go to their physicians on time, and not to delay, because that's critically important. So we all need to come together to do those small things to make lives easier for our overcomers. So great discussion, Dr. Liang. So I would ask you just one thing, and I ask all my guests that I have asked a lot of questions. Is there anything that I have missed that you would want to share with us?
No, I think we've done a great job just summarizing sort of like what the action items, communicate, involve your caregiver, your team wants to help. And kind of, I just try to tell patients it's like a team effort, right? Your healthcare team is one thing, your family and caregivers are another, maybe your employer at the end of the day. Leveraging like community organizations and support groups. I think if we all talk about these problems, we're going to problem solve both on an individual level, so one person's specific problems, but then also like come up with broader solutions. So yeah, your questions have been great.
Absolutely. Thank you. And so I sent you a few names because we just started to do this episode dedications this year for our 2023 series. So who are we dedicating this episode to?
Yeah, we would like to dedicate this episode to Marcia F., Brenda D., Tam S., Valentine W., and Vivian S.
Thank you so much, Dr. Liang. And just in closing, what message of overcoming would you like to share with our audience that's listening today?
Yeah, well, I'm really appreciative of this opportunity, and I'm glad that I watched some of the other coffee chats, and I love how diverse the topics are. And I think, again, community and sharing experiences from all our different perspectives is really the most important part, and it can really bring like a positive sort of attitude to, what is otherwise a pretty stressful, potentially experience. So again, thank you so much. I can't wait to engage with you all more in the future. So
thank you so much, Dr. Liang. This was a fascinating conversation. And thank you for, sharing your thoughts and also shedding light on this very important topic, because, cancer in itself brings so much burden with it. Financial toxicity is something we need to continue to talk about, and so that we can all come together to address it and help our overcomers overcome it. So thank you for all your great insights, and overcomers. Hope this was beneficial for you. I know, as I always do, and as I always tell you, I learn from these experts so much every time they are here. So hope this was greatly beneficial for all of you. So please share this video and this information far and wide with anyone who may benefit from all these great insights Dr. Liang shared with us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you and bye.